Okay, so introductions. My name is Kara Barnett. I'm an associate attending and director of anesthesia services at Memorial Sloan Kettering Cancer Center Monmouth Regional Site. So there I do all outpatient surgeries, IR, GI, OR. And I'd like to also introduce our presenters. So we welcome Doctors Haiti Schreck and Dr. Louis Wen. Dr. Haiti Schreck is a pediatric anesthesiologist and director of non-operating room anesthesia at Dartmouth Hitchcock Medical Center. Her research interest focuses on understanding workload and stressors for anesthesia providers delivering care in non-operating room anesthesia locations, and using this knowledge to improve teamwork and multi-professional crisis management in the NORA environment. She is the current recipient of the Department of Anesthesiologist A&D Glass Scholarship Award, which provides her with protected time and startup funding to examine anesthesia provider workload and emotions during neurosurgical cases in two different work environments, the normal operating room and a remote hybrid MRI operating room. Moreover, Dr. Schreck is developing a mock crisis simulation module for the MRI OR in collaboration with the Patient Safety Training Center at Dartmouth Hitchcock, with the goal of expanding this crisis training across a multitude of NORA locations. Dr. Schreck serves as the Department of Anesthesia Perioperative COVID-19 coordinator. She is a member of the QA committee with a particular interest on investigating non-routine and near-miss events in the NORA landscape. At a national level, she's also a member of the SAMBA NORA committee. So Dr. Schreck completed her medical school training in Munich, Germany. She received her anesthesiology residency and pediatric anesthesia fellowship training at UNC Chapel Hill. She's previously held faculty positions at the University of North Carolina, University of Michigan hospitals. Dr. Louise Wen completed her anesthesiology residency at Stanford and stayed on for a fellowship in medical education and simulation. She is currently an assistant professor at Dartmouth Hitchcock Medical Center and is passionate about medical education and patient safety. So I'm going to turn things over to our presenters. Thanks, guys.
Well, thank you so much for this kind introduction, and thank you everybody who joined in to, hear about really the NORA landscape, how it is different from the main operating room and how interprofessional simulation can play a big role in making our workload and stress better. I'm presenting this talk together with my partner, Louise Wen, and as you will see, we'll split this talk up, but essentially we are working together on the same projects. So we have no conflicts of interests, and you probably all read the objectives. Essentially, we're going to talk about non-operating room anesthesia locations, how they are different in terms of their task load during routine and emergent situations. And we will discuss how the different functions of simulation can help us in that setting. The last part of the talk by Dr. Wen will focus on the debrief component, which is essential to all simulation. So to start you off, I'm gonna just introduce you to a scenario that happened in our hybrid MRI operating room. This involved a 5-month-old child who underwent open craniosynostosis repair. Those who are not involved in these surgeries, it's a long, pretty involved surgery that is associated with massive blood loss and routinely goes along with transfusions. So this procedure happened in the hybrid MRI OR to have MRI image guidance. This suite is 2 floors away from the main OR and therefore is one of our many off-site locations that we staff. Because it was also a research case, we actually do have live footing of the case, and you can see that the beginning of the surgery, the left side of the screen, you can see like the surgeon's view. He was just starting to prepare for the osteotomies. The anesthesia team depicted on the right noted that the end tidal CO2 monitor just suddenly dropped to 0. The rest of the vital signs that you can see at the bottom remained actually normal for this patient and her age group. So of course, the first thought is maybe it's just zeroing. well, pretty quickly it became obvious that it wasn't just zeroing. The saturation dropped within half a minute to just 49%. The anesthesiologist is now somewhere under those trips on the right panel, assessing the airway. The nurse anesthetist is attempting ventilation, but there were no breath sounds. And the surgeon is quite busy just covering up the surgical field, since it was clear that he needed to move out of the way pretty soon. Around this time, it's also when an anesthesia stat call was done. And then, well, fortunately, people were pretty quick, as far as you can be quick in that situation. The surgeon covered up the patient, and within a minute, the anesthesia mask was brought by the circulator all the way from the anesthesia station around the surgical instruments to the head of the bed. The anesthesiologist was able to start adequate mask ventilation. The tube had become dislodged, so that was removed, and things were stable. So what's noticeable is that this is about, a good minute after we first